Good morning, everyone. So today I'll be presenting Dr. Abdullah Al-Ajmi. He is an Omani prosthodontist, graduated with distinction from the University of Manchester in the UK. He holds a membership of prosthodontics from the Royal College of Surgeons. He had his Bachelor of Dental Surgery from Otago University in New Zealand and MFD from the RCSI. Currently, he works as a prosthodontist in the government and private sectors in Muscat. Also, he's part-time visiting assistant professor at Oman Dental College. Please welcome Dr. Abdullah, and I hope you enjoy his lecture.
Good morning, everyone. It pleases me to be here again after 1 year. So, if we get started, if you don't mind switching to the presentation. So, I chose to speak about provisionalization and definitive restoration of immediate implants in the aesthetic zone for a main reason. I see a lot of my colleagues fear the idea of providing a crown on a freshly placed implant in the aesthetic zone. And this is because they fear the failure. They fear that the patient might come to them, to the dental clinic with the implant in their hand. So there are a set of factors that need to be considered to avoid such failure and such risks. Today I will briefly discuss or briefly speak about the history of implants, the impressions, the fabrication of provisionals. I will discuss some cases along my lecture slides, and I will deeply discuss the emergence profile and the definitive material, or the material that you need for your definitive restoration to restore these crowns. I will also speak to you about how to adjust your occlusion. It's a bit of a gray area, I've noticed with a lot of my colleagues. And I will deeply discuss this, and also I'll discuss the polishing protocols. Like, imagine a case like this walks to you and you end up removing one of the teeth, removing a central incisor, which is a very crucial tooth to every human. You don't want to walk out without a central incisor. So what is your alternative options? Removable partial denture, an Essex retainer with an acrylic tooth. Okay, you can do a resin bonded bridge. You can cut this tooth, build it up with composite, make it as an autogenous resin bonded bridge. But how about we just provide a provisional crown that will maintain the soft tissues for the long term, that will give us an outcome like that when we come to the definitive restoration. So I'll just talk a little bit about history. Implants is not a new thing. Like, human beings throughout 1,000 years of time or more have been trying to replace teeth, and this is documented in Abu al-Qasim al-Zahrawi's documents and the ancient Egypt drawings. They've been trying to replace teeth with root-shaped gold, with porcelain, with guttapercha, with you name it, with various alloys. I was surprised that in 1937, Alvin Struck, he used an alloy that lasted 15 years. Later on, Dahl came up with a subperiosteal implant in 1940. Linkau came with the blade implant in 1967. But the major work by Brennemark in 1957, when he was actually testing the blood flow in the femur of those rabbits, he accidentally found that titanium also integrates with the bone. So he kept his work hidden for about 20 to 21 years. Now, almost all of that work that we're having nowadays is based on Brennemark's work. So it all begins with impressions. When it comes to impressions, either you will do a conventional impression or a digital impression. If you do a conventional impression, your lab will turn it into a digital impression. They will scan your model. Okay, this is when it comes to making your provisional. So you scan your model, they will produce an STL file, you'll do the CBCT, and you'll get a DICOM file. A designing software can design your provisional, and either it's milled or 3D printed. It is advisable that you get involved in the designing of your patient treatment. From the beginning to the end, you get involved even in the designing of your implant position, your provisional position. So the types of provisional crowns, either prefabricated or custom made. And the technique of fabrication, either direct or indirect. The conventional way of provisionalizing an immediately placed implant is post-surgically. So you place that implant, okay, and you get either a prefabricated tooth, like an acrylic tooth, a denture tooth, for example, or a custom-made where you actually use flowable to build on that temporary abutment. And this is chairside, affordable, but takes time. And the other way of doing it is the digital way, which is recommended. Okay, and it requires pre-surgical planning. You'll produce an STL file, DICOM file from your CBCT. You'll mill or print the surgical guide and the provisional crown. It is expensive, but will save you a lot of time if it's done pre-surgically. If it's done post-operatively, after you place the implant, you place the scan body, and you take a scan of that scan body, send it to the lab, they will make your provisional crown. But it will take more time, and it is expensive. Both ways, the conventional and this one here, are doable. And I'll show you some cases. So you can use a modified acrylic tooth from the denture, from a denture, or from the lab, sorry. Or you can directly build on your temporary abutment. I've seen some of my colleagues cutting that temporary abutment in the mouth. Actually, you just mark that temporary abutment, you cut it outside the mouth. You don't want any remnants of that temporary abutments to go into your socket. And you shave it and you polish it after you build it with composite flowable resin. You shave it, you polish it, you use a polishing protocol. And don't ignore polishing. Take your time polishing it. I'll show you why later on. Assess it and try it, adjust it, and add more if needed. This is for the patient satisfaction. Don't glue it to the next door teeth. I've seen some of my colleagues bonding that temporary or provisional crown to the next door teeth, and I'll explain to you why not to do this later in this lecture. This is how it looks after 3 to 4 months. This is a different patient, but this is how it looks after 3 to 4 months. This patient here, I lost him. He came to me, I placed an implant, and I provided a provisional crown. And the reason I lost him, he said to me, we had an argument. He said to me, he came after, I think, 5 months, 6 months. He said to me, I don't need a definitive crown, I'm fine with this. I said to him, no, you need one. This is made chairside. This is made chairside. He said, it looks really nice, I'm fine with it. So anyways, I took a final impression, sent it to the lab, he never came back. So now it's about 8 months. So you might have problems with these, you know. Anyways, so surgical guide, you get your 3D printed provisional. This is pre-planning, pre-digital planning, and we're working on the upper left 5. So that's extracted not with a tweezer, it's extracted with minimum trauma using periotomes and the smallest luxators, the smallest couplant, and then I walk my way to the upper size. Okay, so you take that gently. You don't traumatize the soft tissues around. Some of my colleagues would tend to remove the soft tissue here and thinking that this is granulation. It is possibly granulation tissue, it's possibly inflamed gums, but you don't remove that. You keep it. It's not going to cause failure for your implant, but it will cause major problems. Later on, I will explain this. Okay, so you place your implant, and then you adjust your provisional. So there are 2 points to consider when you build your provisional crown on temporary abutment. The temporary abutment platform and the level of the gum So you go straight and concave. Straight and concave. You don't have to fill it down there. You don't touch the soft tissue down there in the socket. Okay, you can do all of this outside the mouth, especially if it's pre-made, especially if your provisional is pre-made. Okay, so there are 2 points you need to consider. The platform of the temporary abutment. Okay, you go straight and then concave and then towards the gum line. And this is immediately after I finished. So it took me 1 hour, about 1 hour. So the patient appreciates this. Another case which we began with, so this patient came to me and I asked her, what happened to you? Her husband was next to her. And she was silent. She stayed silent and was there. And he said to me, she fell on her face. So I doubted that because I had only the front teeth broken, nothing else. It's weird for someone who's an adult to have broken teeth like that. The upper left one was laterally luxated. It was hopeless. The adjacent teeth to that, the upper right one, the upper left two, needed root canal treatment. So I did the pulp exturbation for the upper right one, the upper left two, and I had to remove the upper left one. So I had to remove it, assess the socket. The angulation for this one wasn't favorable. I placed my temporary abutment, and the angulation was off. But I provisionalized it. This will show you how provisionalization, without any bone grafting, without any soft tissue grafting, can actually maintain the peri-implant soft tissue for you. So the narrower the implant, the better. The better the emergence profile, control, the better the maintenance of the interproximal bone, and therefore the maintenance of the papilla, the better the maintenance of the buccal bone as well. So, and then you can veneer it. You can veneer it with flowable composite to change the shade and to match the adjacent teeth. A very major factor that you need to consider. A lot of my colleagues come back, their patients come back with loose screw, a fracture of the abutment, and so on. Always check your excursive movements. And excursive movements are not just like right and left, but no, front, backwards as well. All of these movements you need to be checked. Okay, check that, and don't let your provisional implant touch, especially if you've freshly placed it. Okay, so make the composite touch. There's no problem with that on both sides. And as you can see, no contact upon excursive movements. And composite touches on both sides, just to protect the provisional crown. And this is how she came, this is how she left, and she appreciated it. So pulpectomy on the upper left two, upper left one had an implant and provisional, and pulpectomy on the upper right one. So when it comes back for the definitive restoration, so we made her custom-made zirconia crown. So as you can notice that I use rubber dam. I lifted the margin. Okay, I lifted the margin of the custom-made zirconia crown. You remember that resin might flow and ruin your soft tissues, right? So that's why you need to lift your margin. You need to lift your margin. Your rubber dam will be placed at this level, about this level, below the restorative margin. And your gum line is expected to be somewhere above that. Okay? And then you just cement the zirconia crown. You tack cure it, remove the excess. You remove the excess of the resin. And then you remove your rubber dam. Very simple. From there to here. And this is how she looked immediately as I finished. And that inflammation up there was because I didn't polish my provisional very well. See how the gum was inflamed, and see how as soon as I delivered, the gum healed very well. And this is after 1 month. So she came back to me after 1 month. that inflammation healed well, but the patient wasn't taking care of the oral hygiene. So I found some staining, plaque retention, and she said to me, I use water floss, but the water floss actually had two levels, and she didn't use them properly. So I gave her another chance, gave her instructions, and I reviewed her after 3 months, and she came with a better oral hygiene. So this is another case where I planned digitally, and we ended up in this smile. So she had multiple implants, a lot of implants, and she is aesthetically demanding patient. And she refused a lot of procedures. She refused bone grafting. She wanted to finish as quick as possible. So with the provisionalization of that lateral, which is off to the labial aspect, you can achieve a nice result, especially with the peri-implant soft tissue. Now, why immediate provisionalization? It's less invasive, saves time, saves money, and saves your soft tissue and the crystal bone as well. And we'll show you some radiographs. And it is aesthetically pleasing. It is very highly satisfying for the patient to walk out with a provisional crown. So this is the patient after we finished. You can see the pink tissue still there. Okay, so the position, the size and the position. So where to position that implant mesiodistally? All I want to say, the message that I want to say, you guys know where to position it, but all I want to say is don't touch the adjacent teeth, okay? Avoid touching the adjacent teeth. Avoid the crystal bone of the adjacent teeth, okay? And avoid the removal of supracrystal attachments of adjacent teeth. So this is where a lot of my colleagues actually remove the soft tissue, thinking that this is granulation tissue or that's supracrystal tissue, which is of the adjacent teeth, which actually will maintain your papilla in the future. A lot of my colleagues actually remove that, and I've seen it, I've witnessed it. So in terms of criteria for immediate implants in the aesthetic zone, there are patient-centered requirements, and there are several preoperative and intra-surgical conditions. And this is not to be discussed in this lecture, but part of this is just to mention that this has to be met. And then the intact socket walls have to be there for your implant. You cannot just place your implant without socket walls, definitely. So facial bone thickness of at least 1 millimeter. Thick gingival biotype is what is recommended, although some of the cases you see here are thin gingival biotype. No acute infection at the site, and you have to have an abundance of bone, an insertion torque of 25 to 40, although some of the cases that are presented, or I'm going to present later in this, had maybe 10 to 15 Newton centimeter of torque. An occlusal scheme, because if you adjust your occlusal scheme, if you understand your occlusal scheme, your implant is not going to come out. It's not going to come out. It's going to stay there. It's going to osseointegrate. And patient has to understand this. Patient has to understand this. One of the strongest messages that you can tell the patient, you can say to him, if you bite on that tooth, if you eat a steak on that tooth, or a piece of meat or nuts, it's going to come out and it's going to fall in your hand. Okay, so they will listen to you and will follow your instructions. So don't touch these areas here. Don't touch them. Don't suture them. So this is another case. Periotome is the first thing I use to remove these teeth. And it comes in different angles, and you can use other tools as well. You can see where the periodontal ligament being lacerated and cut. You assess your socket, you place your implant. Another case that came to me with broken and glued upper left one with super glue. And she said to me, I want to replace this tooth. removed that tooth. It came out in 2 pieces. Assessed the socket, prepared, assessed the trajectory, the depth. I wanted that implant to come out of the cingulum. You can notice that this implant has very shallow threads. It's not ideal for provisionalization and immediate loading. It's not ideal at all, and it's non-platform switching as well. Jumping gap, it's advisable to fill it with slow resorption bone graft. You place your temporary abutment, you assess the trajectory, and then I made the provisional crown, fitted, and it was hand fitted, hand tightened. Because as I explained to you, if I over tighten it with my hand, the implant would spin. It's really difficult to use shallow threads implant to actually provisionalize. This is immediately after I finished. This is the definitive crown. It was a replica of how the original crown looked. This is not, the emergence profile is not what I made. It's an exact replica of how the tooth was. So, and you are expecting to have connective tissue closer to the abutment platform, and then junctional epithelium, and then the sulcus. And we'll dissect this topic further. So this is how she looked immediately. She requested that diastema there. After 1 year, she came back. She had plaque everywhere with defective composites that I had to replace. But I was surprised that there were no plaque on that upper left central incisor. And this is usually because of the lab. If your lab highly polish the ceramic after they finish, you'll end up with very smooth ceramic that the plaque doesn't attach to. But usually, porcelain is bacteria friendly. Okay, so this is how it looks occlusally. I didn't place any bone graft in this case, or even soft tissue. So I was surprised with one thing, that I still have papilla. I was actually surprised with this. I discussed this with some of my colleagues. I said to them, I still have papilla, and I have an open contact. So I have an open contact between the 2 teeth. I still have papilla. I said to him, Tarnow in 1992 said that if the distance from the bone crest to the base of the contact point is 5 millimeter or less, you'll always have papilla in there. Okay, but in this case, I don't have a contact point. I took an entire tooth out. I placed an implant. I didn't place any bone graft, and I placed my provisional, and then I placed my definitive restoration. So when it came to actually discussing this topic, we come down to the anatomy that we have between the natural tooth and the alveolar bone. We have the periodontal ligament, then we have the supracrystal attachment, the connective tissue, and then we have the junctional epithelium intact, not touched. I did not touch it. So if you touched it, if you removed it, I don't think you would have papilla there. Like if I touched that, I don't think I would have papilla still remaining there. So the papilla is there because of the next door tooth. So I did not violate that biologic width of that next door tooth. See? Another case where a provisional crown is delivered for a patient. See how the soft tissue nicely healed around it? So the yellow represents the connective tissue that you are expecting, which is very important for your crystal bone maintenance, and then the junctional epithelium, and then the sulcus. So I've been seeing this in almost all of my radiographs, like the papilla and the crystal bone still there. And it will give you better long-term soft tissue stability. Okay, what if you suture? Like, I advise not to suture. What if you suture? What would happen? So you might end up with scars like this. But with time, these scars may go, or may not. So we're looking at the upper right 4 now. So another case of a smoker, a very heavy smoker. This guy is a very heavy smoker, so I did some bone grafting for him. I placed an implant. I didn't provide a provisional. I was surprised that the bone actually went over a non-platform switching cover screw. Took an impression, sent it to the lab. Yeah, took an impression, sent it to the lab, and asked the lab for the darkest tooth possible. Because he had really dark teeth. He didn't like, he had really dark teeth, and I had to fit the crown. And if you notice that the crown subgingivally is white, subgingivally is pure zirconia, it's monolithic zirconia. Okay, it's polished zirconia. This is immediately after fitting it. So I put this case up to show you the adjustment or the marks for the excursive movements. You can see them, checking that, taking my time checking. So it's not just delivering the crown, it's after delivering the crown. There's some work that you need to do to make sure that this would last very long. So this patient is bruxist, so I had to give him a night guard. So now, the shape of your definitive restoration, how should it look like? Okay, we have the convex and concave emergence profile, right? So we have which one we want and where. We want both, but which one we want and where. So initially, you want a straight concave shape of your definitive restoration, as well as your provisional crown. Okay, straight, then concave, and then convex. Okay, convex, why? To support your soft tissue. Okay, so you end up as in an S-shape emergence, an S-shape emergence. All right. We talk about this, and I talk about this in workshops, but I still see like ridge labs, and I see definitive restorations that are not soft tissue friendly. Okay, so why we do this? Because we are expecting to have connective tissue either shared between the abutment and the crown, or on the crown. Okay, and this is based on what is the level of the implant that you have. Okay, so connective tissue to attach at the area where it is straight, and then concave where the junctional epithelium, and then convex where the sulcus is expected. And this would provide for you long-term stability of the peri-implant tissue. And this, if you apply it in your provisionals, it would actually provide long-term peri-implant soft tissue starting from the moment you extracted that tooth. So in implant systems, we prefer to have that part there straight. In terms of materials, the options out there are either zirconia, lithium disilicate, or porcelain fused to metal. and zirconia is the choice.
Dr. Abdullah,
Why
sorry to
it's the
interrupt.
choice?
Dr. Abdullah,
Yes.
we've got 10 minutes left. Just
Kim?
10 minutes left for the lecture.
Okay. Because it's a polycrystalline ceramic material, polymorphic material that doesn't interact with anything. There is no glassy matrix. It's white color. White color is important for the aesthetic zone. 2 days ago, I had a patient with grayish gingiva because of the abutment that she had, and I had to replace it with something like zirconia, okay? The zirconium custom-made abutment. So there shouldn't be any glazing or staining or layered porcelain subgingivally. Ask your lab to polish it. By the way, even if you say to your patient, don't layer that subgingival part of the abutment or of the crown, they would glaze it for you. You won't see the glazing. You'll see it shiny. You won't see the glazing. You'll see it shiny. You don't want glazing there. You don't want any traces of porcelain, because glazing is porcelain. You don't want staining. Okay, so you don't want anything of that subgingivally. But above the gum level, you don't have a problem. Layer it, stain it, glaze it. Okay, and this is an example of that. So always lift your margin. Always lift your margin to avoid any escape of the resin cement. Because we hear that cement will cause peri-implant disease. This is true, because what they do, this is what we've noticed. What they do, they don't lift the margin up here, where the gum line is, where the sulcus is. No, they place the crown on the abutment immediately, and everything flows down subgingivally. Okay, so polish even interproximally. I ask my lab to polish that area, not to glaze it interproximally. And now, when it comes to zirconia fitting another zirconia, or zirconia crown fitting an abutment made of zirconia, the way you do it is, or the lab does it, so silica-coated alumina air blasting is one way. Another one is alumina air blasting if you don't have silica-coated, or selective grinding, selective zirconia grinding. A lot of labs do alumina air blasting and zirconia selective grinding. And then you would use silane coupling agent and an MDB monomer. And usually this is found in metal primer. And then you use your resin cement. Now, when it comes to occlusion, how much occlusal force and where you want on these teeth or on implants. So this is all comes back to your understanding of the physiologic mobility of teeth and implants. So teeth usually move, right? And they move because of what? Because of the PDL. And they move up to what? 28 microns, up to 28 microns. And this varies from a person to another. But implants, they don't move. They are rigidly sitting there. They don't move. Okay. Some reported that they move up to 5 microns vertically towards the apex, but they don't actually move. So from this understanding, it comes that the problems that we see. Fractures of the crown or the abutment, okay, screw fractures, or implant fractures if you don't adjust your occlusion properly. Or sometimes you see this frequently, abutment loosening. You can see an abutment getting loosed from the crown, or a screw loosening. So these are the common problems that we see. Now, these teeth are expected to move more than the implant, right? So what do? You check your light static occlusion, okay, and then you compare it with your heavy bite or clinching. So you compare them both. And I will show you a video of that. So implant should not touch until teeth no further intrude, because teeth will run away, they will intrude. The opposing and the one below it, the antagonist will intrude. 5 minutes? Okay, nearly done. So what do? So we're expecting these to move up to 60 microns, and those two would not move, okay? Also, when it comes to the tactile sensation, and this is also related to occlusion, Teeth can feel 8 to 10 microns, the size of food. Size of food down to 8 to 10 microns can be detected by natural teeth. Whereas implants, the food size particle that needs to be about 50 microns to be felt. So you are expecting heavier bites on these implants. Also, these natural teeth horizontally move more than implants. Okay. And this comes when you want to restore an interproximal composite. And also, we have problems that teeth move with time, and implants stay where they are. After 10, 15, 20, 30 years, especially if you are local, the patient might come back to you with an implant stuck up there, and all the remaining teeth have moved. So you need, from a medico-legal point of view, you need to explain to the patient that teeth will move. You need to explain to your patient, especially if you are especially if you are doing implants in the aesthetic zone. So you know that teeth move. You can treat them, and if they are next to an implant, you can treat them as natural teeth. It's fine. Just restore that interproximal caries. So this video shows how a light contact, patient bites now in a light bite, okay? Light bite, natural teeth, the artificial paper catches. Now on implant, it's not catching, it's the same bite. And now I said to him, clinch. I said to her, clinch. See, it teared my articulating paper.
Unfortunately, Dr. Abdullah, we have to stop here.
Stop here?
So we'll have time for the questions. Any question from the audience?
Seven slides left. I will finish them. 7 slides. Okay. Polishing, when it comes to polishing for provisional crown, use your yellow fine grit diamond burr and then use a polishing protocol for your composite. Don't neglect this. This is very important. If you come to polish your zirconia, don't use large grit. Use fine grit diamond burr. And then use a polishing protocol for that. This is the end of my lecture. Thank you. How many minutes left for the next one?
Hello, Dr. Abdullah. Thank you for the presentation.
Welcome.
Is there any cases you would not provisionalize right away? And what are your post-op instructions for your patients after you provisionalize a patient?
Yes. So one of the cases that I did not provisionalize, the one with the large buccal defect the smoker had. And the smoker is a very high risk. You don't want to see the patient walking back to you with the implant in their hand. It's a bad reputation. It never happened to me, alhamdulillah, so far, but might happen. So the other thing is, the other part of your question is so the most important thing, like you tell your patient, don't bite on this provisional crown. So you did everything from your side. You did your occlusion. The occlusion is a very important aspect. It takes time, but the occlusion, the polishing of the provisional crown, all of these are very, very important. So you do all of that, but then you come and say to your patient, don't bite on this provisional crown. It will come out in your hand. Just say this to them. And they will never bite on it, and it will succeed. Trust me, it will succeed. This is one. 2, I advise them to use water floss after 10 days, about 10 days, to use water floss. Khalas. Use water floss to clean interproximally. And never use dental floss. Yeah. Thank you so much.
So the next lecture will be presented by Dr. Mahmoud Ahmed Qaabaazard, who is a dual board certified prosthodontist and dental implant surgeon, as well as a founding member of BYTE Digital Dental Lab in Kuwait. He earned his DDS degree from Virginia Commonwealth University in the year of 2011, received an AEGD certificate in the year of 2012 from Case Western University. Furthermore, he pursued his advanced postgraduate studies in prosthodontics at the University of Southern California in 2014. Following his prosthodontic training, Dr. Qaabaazard continues his advanced studies in surgical implantology at Harvard School of Dental Medicine in the year of 2017. Currently, he's a full-time private practitioner at Qibla Dental Center, where in collaboration with BYTE Dental Lab, implants digital dental workflow in his daily practice. His level of expertise dives mostly in digital-based comprehensive treatment planning, cosmetic and minimally invasive dentistry guided implant surgeries, and full mouth rehabilitation on teeth and implant.
Go ahead. Okay, good. Okay. Good morning, everyone. Thank you to the Kuwait Dental Conference and Association for this kind of invitation to be presenting my topic, which I hold dearly, the full arch rehabilitation in the digital era. I put this list of universities that I had the privilege of attending only to show how the transition was when we were doing our treatment and our cases from the analog workflow and then progressing, as dentistry has been progressing more so into the digital. We've been implementing more and more digital workflows in our daily practice. As was said, I'm a full-time practitioner at Qibla Dental Center, implementing the complete digital workflows on all my cases, whether it's cosmetics or surgical. And I work in close association with Byte Dental Lab, who they are providing me the support to be able to provide these kinds of treatments and outcomes. So these are some of the cases that I had the privilege of treating over the years. All these cases presented with teeth that are non-restorable or needed full extractions and rehabilitation on implants. And as you can see, starting from the bottom and then to the top, all restorations are designed differently. However, the workflow remained the same. Is this normal? It keeps on and off. Okay. So my topic is the lecture is going to be talking about the digital data acquisition and virtual treatment planning. This will be followed by discussion about guided implant surgery. And then we'll be talking about the digital-based prosthodontic rehabilitation by taking scan bodies and final impressions for the final prosthesis. At the end, I'll have one case that I will be presenting from start to finish, discussing the entire workflow, putting everything together. So data acquisition. When we're talking about the data acquisition, we're talking, you wanna go ahead. Guess we're not digital yet. Okay. Data acquisition, we're talking about certain sets of data that we need to collect in order to start the digital workflow for these types of cases. And we're talking about data acquisition. Panos Papsperlakis presented a very good paper that discusses the necessary information that we need for these types of cases. And these are an intraoral scan, a CBCT radiograph that gives us a 3D dimensional imaging of the bone, and a facial 2D and or a 3D face scan. Okay? All this information gets to be transferred into the computer-aided design software for the virtual treatment planning. If we talk about the intraoral scanners, we understand that there are multiple intraoral scanners in the market. Each one has its own feature. Each one has its specific technology, specific software algorithm. And for the most part, each one has a different feature that separates it from the other. But in essence, the purpose of an intraoral scan is to generate a file of the impression of the oral cavity so that we can transfer it into the computer-aided design software. So it's either an STL, Standard Tessellation Language file, or an OBJ-PLY file, which is a color-rendered file as opposed to an STL file that is non-color rendered. Okay? So what's the accuracy of these scanners? Now I'm talking about full arches, not single teeth and all. So there are papers that are published over the years from 2020 all the way to 2023 that looked into these factors, whether it was in vivo studies, meaning they were tested on patients, or systematic reviews. And they've seen as time progressed, these scanners had gotten to be much better and better in their accuracy of scanning, with a discrepancy of around 100 microns. This is considered as clinically acceptable in relation to conventional impression making. Now, Martha Leon is one of the pioneers in literature and research in digital dentistry, and she and Herman Gallucci published a paper that discussed what influences the accuracy of a full arch scan. And we have all these factors. Now, I'm not going to dive into each of the factors, but us as clinicians now entering the digital era, we have to understand the equipment that we are using, the machinery we're using, the scanner type. The software of the scanner has a part in accuracy. Operator experience, the clinical condition in taking a scan in a room that's heavily lighted, that could affect the accuracy of the scan. The scanning pattern, so every company has a specific pattern that it recommends for scanning their cases, and each the dentist has to follow the recommendations provided. Patient factors such as the arch that's being scanned, whether maxilla, mandible, dentate, partially edentulous. The more dentate the patient, the more accurate the scan, as opposed to a completely edentulous, because you have the soft tissue either movable, that does not scan well, or that's attached, we're able to scan. And then we have to consider the scan body types that we are using as well. Now, the literature is still coming up as far as coming with a recommendation for which type of scan body is ideal. However, in the market now, the types of scan bodies, the material used, are doing the job well. So the CBCT radiograph, the purpose, as I said, is to give a 3D rendering image of the maxillofacial structure of the bone so that we're able to start the implant surgical planning. But the beauty of this information is that once I take a CBCT scan, I'm able to import the STL file or the intraoral scan with the CBCT and have a diagnostic wax-up made so that I have the end in mind when I come down to planning my surgeries, and we'll see that as we move forward. The file that comes out is called a DICOM file, a .dcm. I mentioned this to you because it's important to understand that if you take a CBCT, you need to know how to use it or where to transfer it. When you export it, you need to export it as a .dcm file, and it comes in multiple cuts as a folder and not just a single file, so that you're able to transfer it into the design or the implant planning software. So let's take this case for example. This is a dentate patient. The plan is to extract the maxillary teeth, full arch implants. This patient presents with natural teeth present, not heavily restored. And this is important because some of the patients that we see on a daily practice, they have multiple restorations, metal ceramics, that could affect the accuracy of the CBCT or the image quality. So for a patient with natural teeth, and if we take a CBCT and we adjust the threshold of the CT so that we can start the process of what we call segmentation, is to separate the maxilla with the teeth so that we can start the planning for the implant of the placement in the maxilla. And you can see how we need good hard tissue, which are the teeth, in order to put these files together between the STL file and the DICOM file. And you can see from the green line how accurate the matching is. Okay, so this is with teeth and natural teeth, and we're able to easily match. The group from Harvard went ahead and wanted to see what are some of the issues that do affect the quality of the CBCT. And the factors that influenced it were the metal artifacts, whether it is a PFM restoration or a zirconia restoration. It creates something called scatter. If you look at the CBCT of a patient fully restored with PFM restorations, you're going to see something called scatter, which is the reflection of the radiation back, and it goes in a horizontal direction. And we'll see an example of it, but this makes it unclear on how to match this data set. The soft tissue lips, once it drapes on the ridge, can also affect the quality of the buccal bone being seen. And teeth in occlusion is an issue because if we take a CT with teeth in occlusion, the segmentation, which I just showed you, would be much more difficult because I have to cut from the opposing teeth as well. So you always want to separate the teeth. So to avoid all this, sorry. Okay. So to avoid all this, we go ahead and use markers, for example. To avoid the scatter, we use things called composite markers. We build it up in a vertical direction, not a horizontal direction. Or you use the fiduciary markers, which are the radio-opaque dots that comes in stickers, and you can stick it on the palate. Cotton roll on the vestibule, so that you separate the lips, and cotton roll on the teeth, so that when they bite, they don't go into occlusion. So let's look at this case now. This case is a patient fully restored with metal ceramic restorations, and we need a CBCT. Do you see the quality of the CBCT? When we're trying to go ahead and segment for the planning, I'm not able to match the CBCT to the actual intraoral scan. So rendering somewhat the CBCT useless only if I was going to go freehand. If I was going guided, this is not going to work. Okay? So let's consider this situation. Patient presents with the mandible having acrylic full arch prosthesis set on implants. Now, the acrylic won't show on the CBCT scan. It will be no image. On the maxilla anterior, he had all ceramic restorations. So the CBCT will be clear with all ceramic. But the posteriors had metal ceramics. So we knew there will be scatter. So now if I go ahead and take a CBCT, you see the scatter on the posterior, but the anterior is visible. But what I did was we applied composite markers, these vertical lines, in different positions. So now I'm able to select the teeth that are clear, and I'm able to select the composite markers so that I can put this data set together and start the process of my implant surgical planning. Okay, and you can see how clear when it gets to be merged together. So the 2D and 3D facial imaging, this group tried to see if there is any difference. Basically, they saw that the perception, some would say the 2D was better, some would say 3D. There wasn't a consensus. Now, the information that you get with a 3D face scan is more because you have a lateral view. So if you're setting up for a full mouth, you're able to use the lateral face profile in setting up your teeth, for example, the Camper's plane. However, me personally, I just go with the 2D image. It's much easier on the spot. I don't need to have all these gadgets. And once I have the 2D image, I'm able to use the design software giving me a guideline on how to set the teeth that's aesthetically pleasing. What we're trying to shoot for is a facially driven wax-up, as described by Christian Coachman. So we can go ahead and modify the length of the teeth based on the incisal edge display, adjust the proportions, go with the golden proportion, whichever parameter that you would use in order to provide an aesthetically pleasing setup. Then we go ahead and discuss it with the patient, show him somewhat of a motivational video if we were to do the treatment, what it may look like. After that, we can also go in and do what we call as the digital 3D design of the teeth by merging this data set together, right? So we use the photos, it sets it to the position, and then sometimes we could put it under virtual articulation. And what we can do is we can then start with the digital wax-up. Now in this case, it's a dentate situation, but because I wanted you to see the full face, this is a situation where we were able to actually see the digital wax-up and evaluate. In this case was a ceramic veneers case. We can really study the case and approach it in a minimally invasive way, knowing that I don't need to prepare that much of the tooth to be able to put in a veneer. I already have the incisal reduction based on my wax-up. So this digital wax-up plays an important part. So now we go with the mock-up within the patient's mouth. Now the mock-up is the most important part in the entire process. We don't proceed to the treatment planning for implants until the mock-up has been placed in the mouth, tried in, or a denture setup has been done and tried in. There has to be a trial where we evaluate the aesthetics, phonetics, and the occlusion prior to going to the surgical phase. So now we go into the virtual treatment planning, which is basically getting the information and starting with the wax-up. So this is a case where the patient, young patient, female, and basically teeth were, she lost her posterior teeth, heavily decayed lower anterior teeth, upper teeth already in provisionals. She wanted a full mouth rehab and implants. Simply enough, we went ahead and took an intraoral scan. After taking the intraoral scan, we went ahead and merged this data set with the photo and started with the digital wax-up. We were able to decide that we didn't need to go for the FP3 prosthetic, which is the implant and gingiva. We were able to go with an FP1 prosthetic, which is just the teeth. And this is what we usually strive for, is to provide a natural-looking ceramic restoration that's mainly on teeth. Once this is tried as a mock-up, then we're able to go ahead and do the implant planning. And the planning goes based on the restoratively driven plan. We take factors into account that are biologic, and then we take factors into account such as the emergence profile of the final prosthesis. In this case, we opted for 8 implants in the maxilla, 6 implants in the mandible under a guided surgery approach. So case started this way. After we took out all the teeth, placed the implants, and provisionals were given, final result came out somewhat almost to where we had the wax-up design done. So we already had the end in mind before even starting the treatment. Another case. So the case I gave you now just had teeth. What about a patient who presents edentulous, no teeth, and you want to start the process of digitalizing and treatment planning and all that? Before, we either would have taken a duplicate of that denture, send it to the lab, they would fix it, clean it for us, put in markers, take a CT. Now what we're able to do is just, if we're happy with the denture setup and all that, we just scan that denture. We applied gutta-percha markers on that denture. We did a wash impression of the denture so that I have the accurate replica of the soft tissue that the patient presents with. And you can see in the design software, not only do I have the denture itself, I can create the negative, so I have the actual ridge now. So I have 2 files in my system, not just one. After that, I'm able to merge this data set. Now you see on the left CBCT, this was a CBCT scan. But because it's a denture, it's not visible. We won't be able to see it, so we went ahead and used the points in order to match this data set, which is the gutta-percha markers. And surely enough, this case I had the privilege of treating with Dr. Mshari Abdelhadi. Remember the science? Yeah. So this was the before, this was the after result. 8 implants maxilla, 6 on the mandible. Okay, what if a patient presents already with no denture on top and has teeth on the bottom? A workflow that was developed by a Harvard group is that they would go ahead and do a wax rim. That wax rim would then be scanned, and with the photo, we're able to merge this data set together and start with the digital setup. We already have the occlusion in place, and I have the midline marked, so I'm able to start with the digital wax-up. And this is the design that we were actually made for the patient. And I want you to focus on how this design looks, because you'll see it at the end as well, that it almost looks as similar. With the setup done, we go ahead with the surgical planning now that's restoratively driven. And the case was like, case edentulous that way, and as you can see, this is how we restored the patient. Virtual stage provisional. One consideration now, we're still in the planning stage. So we did the wax up now, the setup, mock up, everything good, guided surgery, already planned the surgery. Now, we also have to think, how are the patients gonna leave after the surgery? How are you gonna provisionalize? In our private practice, most of the patients opt for something fixed. They would not leave with something that's removable, which is in their right. If it was in my mouth, I would wanna leave with something fixed. So in that situation, you gotta think outside the box. In a situation like this, a patient presented with multiple teeth that we know we're gonna extract eventually, and I need to distribute the implants in a specific way. Why not keep some teeth instead of extracting everything? So this is what we call as a stage provisionalization. We removed the crowns, we went ahead and have the preparations done. Then we did a virtual extraction. Did the setup for the provisional, and already it was confirmed. We planned for the implants to be positioned in the positions where we virtually extracted the teeth. So some were immediate implant placement, some were delayed. And this is the surgical guide that would sit on the teeth as well for stability. So this is how the lower implants were already placed from before. This is how we placed the maxilla implants, and this is how we provisionalized the patient the day of the surgery. What I'm trying to get you to see is how everything is all pre-planned, simplified, going through the digital planning. Or a case where we know we're going to go ahead and do immediate extractions of all the teeth, and we're going to load the implants. So in this situation, same thing. We already took out the teeth virtually. We already knew the setup would be as it was, or just fixing, maintaining the vertical and everything. We planned for the implant and developed a provisional that is indexed on the palate. You have to also figure out that if you're getting to provisionalizing, picking up the implant positions, you need something that's stable. So this was after the surgery. This is the provisional being picked up in the patient's mouth, delivered, and this is the provisional in the immediate loaded provisional in the patient's mouth. Another consideration is, how am I gonna restore this patient? Am I going abutment level or implant level? In implant prosthodontics, abutment level means that you're converting the internal connection into an external. You're changing the angulation of these axis of the implants. So, for example, in the case on the left, we knew that we were going to go with straight abutments on some and angulated on others. So this is called abutment level when you see this part over here. But if you go into this side, you're going to see what we call as tie bases, vario bases. These are different. These go connect into the implant. But the beauty of these vario bases as well is that they come in different gingival heights. So if I place an implant deep, I don't need to select a base that goes deep into the implant. I can select a different gingival height. This can be planned for in advance, so I know my components before I even start anything. Another consideration is, how am I going to distribute the implants? Am I going to go ahead and do full arch splinted, as you see on the left side, or am I going to go with segmented, as you see in the second slide? Or am I going to avoid anatomical structures such as the sinus or the posterior inferior alveolar nerve, and place the implants more anterior, go with maybe short implants, or have a distal cantilever. These are all considerations that you need to be taking with your patients, and it all starts when you do your full wax up and start placing the implants in the digital software. But in essence, for the maxilla, we usually shoot for 6 to 8 implants. For the mandible, we shoot for 4 to 6 implants, and you can go either segmented versus splinted. Each one has his own philosophy. Another consideration is, okay, anatomical landmarks. You can see that we have a situation where the nerve is really close. There's no way I can place an implant in the posterior, so why don't go angulated implant placement? Now, this group made an interesting study by evaluating almost 150 CBCTs. And what they saw is that previously we used to do the all on fours, all angulated. And the reason they did that is so that they have an anterior-posterior spread of the implants when we're putting in the prosthesis. The abutments used in that before was at 45-degree angulation. Me now discussing this is that so that you open your eyes to the components that you're using. Is a 45-degree multi-unit abutment angulation. So it can give around 2 millimeters of more anterior-posterior distribution. But in a situation where you don't have 45 degree, some companies have 30 degrees. So then comes, how much am I actually gaining? A millimeter? Is it worth placing an angulated implant for just a millimeter? So these are questions that we have to consider, sometimes as surgeons, sometimes as pros.
Victor, 10 minutes left.
Huh?
10 minutes.
La. So guided surgery, I'll go through it fast. Basically, it's speed, patient comfort, better decision making when going ahead and placing implants, knowing which implants to use and all, better visualization of the final prosthetic in relation to the implant, and accuracy. I thank Dr. Hamid Al-Qadi for this slide. The accuracy is based on a few things. The type of guide that's being produced, meaning that there's a tooth-supported guide, tissue-supported guide, and a bone-supported guide. Tooth-supported guides are the most accurate, most stable. Soft tissue-supported guides, for example, on the complete upper arch, may not be as accurate. So us as surgeons, we have to understand how these guides are made, how they are placed, making sure the fitting is correct, because you can have a deviation of 3 to more millimeters if these guides don't seat correctly. So whoever is doing the surgery needs to understand how the guide should be placed and make sure everything is fitting correctly before starting anything. So let's talk about tooth-supported guides. For example, this is a case I did where a patient, I knew I'm going to extract some teeth and keep some teeth. So I went ahead and extracted some of the teeth, had the guide placed the implants in a guided fashion, and this was the end result for the maxilla surgery. 8 implants placed, and this is the provisional in the patient's mouth and delivery after healing, all in a screw retained as pre-planned position. Another case, this is a bone-supported guide. In this situation, this means that you need to reflect more in order to seat a guide that seats completely on the bone. This is a difficult guide, but it is accurate as well. But this case was an edentulous case when we had to go for a bone-supported as opposed to a soft tissue-supported. So we had fixation pins, it was seated on the bone, did the surgery. The maxilla, same patient, we were able to go with a tissue-supported guide, but we fixated the pins to stabilize. And this was the end result. We replaced the implants, 8 on top, 6 on bottom, and had the full arch prosthetic done. Stackable guide is when you have different guides being stacked on top, where you know you're going to be resecting bone, you know you're going to be placing the implants, and you're going to be provisionalizing same time. So this is the guide placed initially, is the bone reduction, and it's fixated and it's not removed. Then comes the surgical guide on top, implant surgery is done and completed, then the provisional comes on top. This is the case, how it started. Remember the case with the edentulous maxilla and the mandible with teeth? This is how the patient left in 2 appointments when we did the surgery, placed the implants and loaded all in one shot under the stackable guide approach. digital-based prosthodontic rehabilitation. This is now us taking the scan of the provisional after healing and ready to start the final prosthesis, the design and to the final. So we go ahead, we implement a technique called the dual scan technique that's started by Panos, by using markers for the maxilla to scan the complete provisional and scan the the provisional and scan the scan bodies, so that we're able to merge the data. In the mandible, we sectioned the provisional and took one segment scan, another segment, and a full scan. 3 sets of files get to be merged together. This is so in one appointment, I can have the setup of the teeth, the vertical relationship done, and then I can go ahead and take verification of the model being produced. This is an important step. Once the model is once we did the scan, we print models, I have to verify these models. So we use GC pattern, all connected, and we go ahead and connect it in the patient's mouth. Sometimes we section and reconnect, and then we put it on a stone model, and then scan bodies and scan it. So now I have 2 files. Digital scan of the, scan of the verification model, and I merge it into the intraoral scan. My design of the final prosthesis is going to be on the verified scan, but the soft tissue and all will use the other scan that has the soft tissue. So this is now setting up for the provisional or the prototype. This is a must in all implant full arch cases, because we need to try in the setup in the patient's mouth. And we knew that we were going to have to use angulated screw channel abutments to restore those, to change the access channel. But for provisional purposes and verification of our models and everything, we proceeded. So this was the provisional that was done. After that, confirmed, we went ahead and started to go for the final setup. So in this case, the final setup was already done, because we just needed to do minimum modification. And this was the end result in the patient's mouth, having an FP1 prosthesis maxilla and an FP3 in the mandible. So you see where I'm getting at, that the pre-planning made us able to reach this end result. This is the result after the placement of the guide. Now, I'm going to discuss quickly a final case, and that sums up everything. It's an interesting case. I had the privilege of working this case with Dr. Hamad Al-Qadi. He's also a partner at Jibla Dental, and we had the workflow that we implemented to treat this patient was simplified because of the digital technology that we use. So the patient presented unhappy with the aesthetics of her ceramic restorations. And you can see already the restorations are fracturing. And if we go in deeper, we see that we're experiencing peri-implantitis of the lower anterior bridge, fractured restorations, recurring caries under all the restorations. She's a full mouth rehab. This is how she looked like radiographically. It's a disaster. So how do you start this case? You know, what would you do? Simple enough. We go ahead, take an STL scan. We scanned the patient. We have the occlusion set. We knew we're going to readjust the aesthetics, but at least we have a baseline. So once the STL scan is taken, then I'm able to go ahead and merge this data set in order for me to be able to perform a digital-based wax-up that's facially driven. And in this case, teeth were set. This is the setup of the teeth. Again, focus on how the setup of the teeth was done, right? Look-wise and all that. Once this setup was done, then I can virtually start the treatment before starting it. So we went ahead, did a virtual extraction of the lower anterior implants, went ahead and also created a shell provisional, so that when I remove the crowns on the mandible, I'm able to have a shell provisional that sits on the prepared teeth. Every step that I take with these patients, I scan. So if I remove the crowns, I'd scan right away. I wouldn't go to the next step until I scan, because this data set will prove to be useful later. And it did in this case. The patient had the provisional place and she never came back. After 1 year, she comes back like this. You can see the upper right bridge is fractured. The lower left crown is broken. So it's almost, we have to restart. But because of the digital files that we have, we're like, wait, we can use whatever she has now. This is not even an correct articulation, but I can transfer this data by scanning and sending it to the lab. The lab is able to connect the new scan to the old scan. That old scan had the data set for the full wax-up.
Dr. Mahmoud, unfortunately, 1 minute. I'll give 1 minute, okay?
Okay, the data set scan. So now, once the scan is done, then we can go ahead and merge this data set with the CBCT by putting in markers so that I can accurately merge the data. So this was the planning we went ahead with. I'm just going to go fast forward on it because we planned STL file in place, the wax up in place, and then we went ahead with the implant placement where it should be, and we developed the surgical guides, which was a stackable guide. So in this case, pin fixation, bone reduction. Dr. Hamid wanted me to show you this. And then the implant placement guide. And as you can see, implants placed correctly, multi-unit abutments correctly placed, and this is how we picked up the prosthesis on the mandible. And the maxilla, we did the same. Because it fractured and I needed some form to register things, composite markers, and a fiduciary marker on the side, because I needed to connect the data set in a tripod way, let's say. That data set was done. We had the digital wax up. In this situation also, we did it in a staged approach. We used the teeth to hold the temporary and one implant that she had to hold the fixed temp on the maxilla. So the wax up was completed, implants were planned for, surgery was done. And after 4 months of healing, we were able to scan same way, maxilla with the markers, and the mandible. We sectioned the bridge and took the scan, and everything was articulated. Verification of the model again. And this is when we went ahead and did the design of the provisional and delivered in the patient's mouth. I'm sorry I couldn't put the rest because I'm rushing now. We did the provisional. Now we knew there's a shift in the midline we needed to adjust, so we just scan it again with the markers in place, with and without, send it to the lab, and the lab will be able to put the data set again together so that they can put the setup that was in the patient's mouth, the provisional. Just a second. That's the provisional in the patient's mouth. And then we'll bring in the lower. You see the shift in midline. Now they're able to adjust that shift, as you see. And then we can go for the final cutback, facial cutback and ceramic layering. So a case was like this, mounted. Once we finish the case, we have the lab mount the case for us in an analog articulator at the end, just so that if we need to check on occlusion one more time or do a clinical remount if needed. This is how the case was finished in the lab. This is how the case was done in the patient's mouth. And this is how the patient looked at the end of the treatment.
Dr. Mahmoud, unfortunately,
2 slides.
We have to finish off right now.
2 slides. And then this is how the positioning of the implants looked at the end. This is the before and after. How it was before, how it was after. Before and after. Before and after. And this is the result in the patient's mouth at the end. You can see how we really changed the life of the patient. So take-home message for all this, if I was to say, Diane Ricau, the late Diane Ricau said it in a nice article, is digital dentistry disruptive or destructive? Definitely disruptive by causing the changes that we're seeing today, not destructive. And I thank you for your kind attention.
Thank you, Dr. Mahmoud قاعةبدرىة, for the lecture. Unfortunately, we won't have time for questions, but okay. I'm sure he will be around, so you can ask him in person.
Inshallah. شكرا يعطيك العافية مشكور